All right, so hi guys, everybody. I'm very happy to be here again. And again, this is a very basic introduction, and I know there's a million questions, so I'll do my best to try and address as much as I can. And any suggestions you leave, we could use in the future. So let's see how much we could get done today in our limited time, and we'll proceed with the presentation. Olivia, I think I'm good to go for the next one. All right, so this is unchanged from last week, right? This is my financial disclosures, my financial sponsors. I don't get anything for this, no grants research. I did speaking for Takeda and Sanofi a long time ago. I do have a small company called Triumph and consulting fees from that. I have no patents, and I do get paid through insurance assessments, Ontario Medical Association when I do some work for them, and I get paid through OHIP, and because I do some work in Alberta, I also get paid through Alberta Health. So that's where my compensation comes from. And again, disclosure of financial support for the program. This program has received financial support from Ministry of Health and Long-Term Care in the form of an annual funding agreement. The program received in-kind support from CAMH and Unity Health Toronto in the form of clinician time and logistical support. And I have not received any paying funding from an organization supporting this program and or organizations products that are going to be discussed in this program. Mitigating potential bias. The information presented in this program is supposed to be evidence-based. The CME program and its material is peer-reviewed, and all the recommendations involving clinical medicine are based on evidence that's accepted within the profession. All the scientific research referred to, reported to, or used in this activity to support or justify patient care recommendations conform to generally accepted standards. Again, as a disclaimer, we're not providing any particular treatment, medical, personal, or legal advice for individual patients or situations. A lot of our suggestions are general educational. And again, this is very introductory given the time constraints. And, we ask that you use your own clinical judgment as well as your own regulations for your professions in terms of guiding the treatment choices for your clients. And if you're going to be experiencing mental health distress because of what we're discussing, please see your own healthcare provider or emergency department. All right, so today we're going to focus on what I call ADHD all day, every day, 365, 24/7, because I think it's a huge part of understanding on how to support and manage ADHD is the fact that ADHD is present all the time. And it's a chronic everyday condition across the lifetime. And you might encounter clients at different points in their life or challenges, but it's present every day. We'll touch base on medications and we'll touch base on non-medications. Next. So, I don't know if anybody's going to recognize this is my picture. I took a photo of Mona Lisa in Paris. Mona Lisa is guarded under glass, and then there's a barrier and there's security. And there's a reason why I bring up the Mona Lisa. Next. So we shouldn't really make diagnoses of people we haven't seen. But there's been an interesting, review of some people in the past and whatnot. And there's actually an article published on this, and I provide reference to this, where people looked into Leonardo da Vinci. And they looked at Leonardo da Vinci and they realized that, he struggled with procrastination, time management. He would start work, abandon it quickly. He had a lot of pervasive difficulties throughout his life. And there is some evidence, although that he was always on the go, he was preoccupied, jumping task to task, and slept very little. And, there's question whether he had ADHD. And most of Leonardo da Vinci's work is actually unfinished. And a lot of the art that we have now is unfinished. And the reason why I bring this up here is that, lots of people admire Leonardo da Vinci. People go line up for hours, for his painting, his work. Because most of the time when we talk about ADHD, we really see it from a perspective of deficits, problem, and an issue. And it's extremely important for us that, again, as clinicians, as people that work with people with ADHD, we don't just promote the message of deficit and focus deficit, but rather we look at strength-based approach. We acknowledge that it's a real condition and work on how do we support the strengths, how do we support people, how do we accommodate, how do we work with this condition. And when all you hear all day are the messages of all the problems, defectiveness, and issues, It's extremely depressing. So I do think that we always have to remind ourselves that people with ADHD could be very creative, achieve, and are capable of lots of talents and have capacity and have lots of strengths, but that gets lost in all the messages about all the problems and impairments that we're bombarded with. Next. Okay, so this is just an example of a case that's very common that I've seen. I'm not going to bring it up because we have another case chosen, but I think I'm going to leave it for you guys here just to when you review the slides, because it might resonate with very common clients that you might encounter. Like this is a very common case I see that are often missed. So I'm just going to leave it, but this is just to kind of help you guide and see how things might present. It's actually ADHD. Next. So why is ADHD such a big condition to consider for all of us, particularly when we're working with clients, whether they're diagnosed, or there's a question about it, or we see that it affects our, patient or clinician, patient relationship? Because ADHD is present 365, 24/7. It affects multiple domains of daily function, right? Because anything that affects executive function is affected in ADHD. And, there's a question about why is ADHD the label that we still use to describe this disorder? Because it only focuses on attention deficit and hyperactivity. It actually misses the fact that this is an executive function issue. And if we renamed it, and there's always a debate about naming it, it would be better described condition. Same with, should we use it as a categorical condition as it is clinically now in the diagnostic, in the DSM, versus as a spectrum condition, because it is a spectrum of impairment and a spectrum of abilities. But that debate is, outside of today's time. So the reasons why we need to consider is because ADHD affects personal hygiene, meal prep, time management, health management, medication compliance, financial aspects, education, employment, relationships at work, romantic relationships, parenting relationships, everything. Safety, safety at work, driving safety, parenting safety, every aspect of safety. Emotional regulation, as I mentioned in the previous presentation, emotional dysregulation is a core feature of ADHD that affects most adult domains of function, and yet we don't pay attention to it much. ADHD affects parenting in so many ways. ADHD affects paperwork, whether it's paperwork at work, whether it's, intake forms, referral forms, whether it's taxes. I can't tell you how diagnostic it is for me to ask people how up to date they are with taxes, right? And so that's a big issue. It affects literally the core of our existence, especially adult functioning. Next. So, part of why it's so important, why the diagnosis is so important, is because we have to look at it as a name it to tame it. Diagnosis provides validation for people's experiences. It also provides direction and guidance. Some people say, well, why do you need a diagnosis? You're 50, you're 45. What's the big difference? It's a huge difference, and an example a patient gave me is that, look, I don't know if you can see, but this is a pen. We have a label for this. But imagine if I asked you, hey, do you mind to grab my pen? You'd know exactly what to do. But imagine if I said, hey, can you grab that object that's long and there's a blue part and there's a gray part and we use it to write? And you might look, okay, that might be a pen, but there might be a pencil. It would be much more confusing and it would take more time. So a diagnostic label, when applied correctly, helps provide clarity and validation and helps guide what we're going to do with it, right? It's a common language. So the value of diagnosis itself is huge for people with ADHD because, again, it just opens up a whole new way of understanding themselves, right? And, of course, guidance for direction and guidance. Psychoeducation is a huge piece in ADHD, huge, 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 huge. And that's where we have to talk about the myths, that you're not lazy, you're not stupid, that because people are inundated with judgments and myths all day that, just try harder. If you really wanted it, you would get it. Because again, that's just complete judgment, stigma, and complete misunderstanding what ADHD is. Everybody in life wants to succeed. Every single person wants to succeed. But are they, is it possible? Or is the success that they want or we want them to do, is it possible for their level of abilities, or do we need to scaffold them in that, right? So again, everybody wants to succeed, but how that looks is different for different people. We forget the strengths of ADHD. We only focus on the deficits and also the treatment options, because not every person's going to get every identical treatment, even in the same family. There's so much individualization around treatment and ADHD. The other thing is, we can't fix or cure ADHD. That's a big frustration for parents often, or spouses. Well, he's seen you for so many times. Why can't you fix him? Why is he not different, right? Because we can't cure this. This is a condition we live with. This is a condition we manage. This is a condition we accommodate. We don't fix ADHD. We don't cure ADHD. The other aspect why we need to understand ADHD across a lifetime is, again, it might present differently across life stages, and the gender aspect, particularly with hormonal changes for women, with the pregnancy changes, with the menopause and perimenopause, and the aging component, like that has to be accounted in when we talk about ADHD. The intergenerational component is huge because it literally affects generation, the parenting. It also affects intergenerational trauma, potentially abuse, stability. It's just such a huge impact when it's untreated, right? As I mentioned last week, often when there's a change in the structure of somebody's life, cognitive demand changes, and accommodations or scaffolding that they had, they might struggle, or it might get unmasked. And somebody might say, well, you've done well for so many years. Why are you struggling now? Because things have changed. And sometimes the change is planned, like a pregnancy, buying a house, move. It's still a change. And sometimes the change is unplanned. Somebody loses a spouse and now they have to manage the household or the children, or the job changes, or, other things that they don't have control over. And all of a sudden there's huge cognitive demand. There is a change in structure, and they're not coping, right? So again, when we talk about ADHD as well, we need to look as what are the functional deficits from a strength-based approach. You struggle with attention. Okay, how does it look for you? Because one person struggles with inattentiveness differently than somebody else. Not every single person with ADHD struggles with driving. Some people are hyper-focused during driving. They love it. They enjoy it. And other people get overwhelmed. They get, very distracted during driving, or they're speeding, or they're more impulsive, and there's road rage. They all have ADHD. The functional impairment is not the same, right? So that's what we need to understand. What are the functional abilities? What are the deficits? And how can we work with that together? And that's where occupational therapists are key to usually bridging that, because they really know how to assess it and bridge that. So huge assessment of how does that affect you? How do you function with that? It's not what grade you got in school. How did you get that grade? How can we help you continue getting whatever grade if you're in school or function? So first, the WISE Functional Impairment Scale is a nice way to start and understand where people struggle with function. It's kind of a nice survey. I do it all the time with patients, and then we kind of take a look in areas where they're affected, and then we kind of can compare as we go along, because many times people don't even know that it's ADHD that's affecting them, because they never knew life differently, right? ADHD has always been there. They've never done anything differently. And to realize that, hey, this is actually an issue, they might have never actually put into together because nobody brought it up to them that actually ADHD related issue. Next. Okay. So again, I mentioned this last time, when we go through transition across life, the cognitive demands increase. They don't decrease. As we become adults, 18 to 25, that transition into adulthood, we have to do more. We have to be more responsible. And we often lose scaffolding. The parents often pull back, or any supports or any programs we were in often pull back. And yet you have to do so much more. So there's a lot of difficulties that arise 18 to 25 in that transition age, a lot of difficulties, right? So this is a huge emphasis that I hope that, everybody understands, is that transition points are huge at unmasking ADHD or destabilizing somebody who might have done well. Next. Okay. Again, these are some of the symptoms across that we mentioned last time. So I'll just leave that slide for your information. Next. Okay, so this is a chart that I often do with my patients, when I talk about understanding their function, because nobody's life starts at 5 o'clock. And that's, again, old way of thinking that you give the medication once in the morning, it only lasts 10 to 12 hours, wears off around 5, right exactly when we transition into a different stage of functioning, which is usually parenting or other tasks. Nobody stops their life at 5. Nobody stops working at 5. There's no jobs anymore that stop at 5 o'clock. Most of us have to do stuff after work. Most of us are catching up on work. parenting, finances, second job. You know, many people now have second jobs in the evening. Many people have to take care of their parents. They have to take care of other people. Work doesn't stop at 5 o'clock. There's no 8 to 5. Okay. That does not exist. So this is an example of how I break things down with my patients to understand what tasks they do so that we could actually understand what supports they need. How does the medication work? Is it enough coverage? Is it not enough coverage? How are they functioning? Right. And this is just, I call it daily life demands of an average adult. And you could get people to break it down because obviously, you know, depending on what they do, it might vary the hours. But this is just an example to understand the executive function over the 24 hours and where they struggle and what accommodations they might do. And putting things on paper, making it more kind of concrete on paper rather than in their head works a lot better for a lot of my patients because then we can actually target particular things or particular transition points or issues that arise. Next. Again, this is what across the lifetime, as you could see just visually, things that we have to do increase and things that might help kind of also again increase, including driving safety, including I cannot explain enough online behavior and sexual behavior that gets affected. I can't tell you how many people I've seen who got sexual harassment complaints because of an impulsive and inappropriate comments that was made at work or in the wrong place. It wasn't meant to be sexual harassment. It was just comment was made and then results in lots of workplace issues, right? Like those are big things. Or online behavior, again, big things that kind of happen. Next. So when we talk about the medications, CADRA guidelines have a nice review of the medications, and it's very clear, it's accessible to all, so anybody can take a look at that. So when we talk about choosing the medications, it's a very complex choice. We always have to look at, is there any medical issues that might contraindicate the medications? Because the ADHD medications can cause side effects, particularly affect the heart, high blood pressure, and other issues that can make, you know, get things worse. So we do have to look at the medical stability of the patient and contraindication. We have to look at the cost. A lot of these medications are expensive, and if you don't have coverage, if you're on EI, which does not have medication coverage, it's hard. And so some programs will have some supplements or some cards that you could try for free, but it's really hard. Adherence is always an issue because, again, with ADHD, adherence is a big issue to any medications, especially their own medications. And as per CADRA guidelines, you know, if the patient is cleared for trying medication, long-acting stimulants are usually first line. By long-acting stimulants means that they work 10 to 16 hours, usually a day, depending on the medication, but you do have to take it every day. It's not a medication like an antidepressant where it builds up and then, you know, there's some effect in between. It works the same day. Also, again, these are the first line medications. There are some medications that we use what's called off-label, meaning they were not indicated initially for ADHD, but they can be helpful because of the mechanism of action. And so off-label would be something like Wellbutrin, which is an antidepressant that increases adrenaline and dopamine. And also some antidepressants that have adrenaline in it or norepinephrine could be helpful. So with ADHD, the important neurotransmitters are norepinephrine and dopamine is what we need for ADHD. And so some of the medications that target those two will also be used and can be helpful, but they're not first line. Clonidine and guanfacine are blood pressure pills that can be used for ADHD. They're approved in children. We use them more often in children, but they're very, very useful in adults, you know, especially guanfacine I use a lot in the evening. It can help with some of the inattentiveness, emotional dysregulation, some of the impulsivity. And so I often will combine the guanfacine with a stimulant, you know, if no other medical contraindications. Modafinil is used in the US for ADHD. It is not approved in Canada, but again, it can be used off-label if the other ones, if there's any issues or they're not working. Unfortunately, in Canada, we have very limited number of stimulants in comparison to the US and what we get on the market. So we're quite limited with what we have. But CADRA guidelines has a nice table that you could review, and it's there. Next. Again, there's sometimes concerns about ADHD medications causing issues. And does it increase your risk of addiction if you're started on stimulants? You know, no, it's not true that it does. There's, again, in terms of newer information over the past year, Olivia, if we can go to the next slide. There was, okay, so it's going to be the next one, but that's okay. There was a study in JAMA talking about increased cardiovascular risk This is it. Yeah, increased cardiovascular risk from stimulants. This is a big study from Sweden, and kind of goes in detail. And there was concern that increased cardiovascular risk. So that's risk of heart attacks, arterial disease and whatnot. They looked at methylphenidates, dextroamphetamines, alextroamphetamine, which is Vyvanse, and atomoxetine. And again, it looked like there is a longer cumulative risk of cardiovascular disease. However, that doesn't mean that we shouldn't use these medications. It means that we have to consider that more when we're making individual decisions for patients. And we have to balance it that untreated ADHD in itself carries significant mortality. So, Kadra had a response to that explaining, what this study means, and just reminding yourself that, we do have to look at this as a risk and benefit analysis. This is not all or nothing decision. And, the JAMA study did not come up with specific guidelines or how often we should monitor the patient, with ECGs or high blood pressure and whatnot. There's no clear guidelines. So that is something to keep in mind over the past year. But again, none of this is an absolute. It's you take a look at this with each patient, you discuss this with each patient based on individual risk factors, benefits, and what you are trying to help versus not, right? So again, untreated ADHD in itself can cause people not to comply with medications or take care of themselves, miss appointments, and increase risk of cardiovascular issues in the first place. So it's not all or nothing. It's always risk and benefit analysis. Next. So this is bipolar and ADHD. Often people will be like, well, they have bipolar disorder. Can I treat? What to do? It's actually very common that the two occur together. Bipolar disorder tends to be episodic, and ADHD, again, is there every day. And the CADRA guidelines say that, we can treat ADHD in somebody with bipolar. We can definitely treat it, but you have to stabilize the bipolar disorder first. You have to stabilize it with a mood stabilizer first, and then the medications and stimulants can be added. And again, careful monitoring. You have to carefully monitor about, what's happening with both conditions, because the worry was always about the stimulants increasing the risk of triggering a manic episode and whatnot. But no, we can treat. We just have to treat the bipolar first and then manage the ADHD. And the way I talk about ADHD is that, ADHD is like the floor onto which all the conditions are landed on. If we don't treat ADHD, people often struggle to follow up and participate in all the other treatments, including their appointments to follow up for bipolar disorder or anything that they have to do. So both are important, but of course, with bipolar disorder, that does have to be stabilized before we add stimulants. Next. Often people will tell you, well, pot helps me, or somebody told me to do this, or, cannabis solves my ADHD. Cannabis is not a treatment for ADHD, okay? CBD is not a treatment for ADHD. It's not in CADRA guidelines. It's not a treatment for ADHD. So if your patients are asking you, what about what I've smoked this? What about this? As far as evidence goes, in 2024, in August 2024, that is not an evidence-based treatment. What it might be in 2030, I don't know. But today, that's not an evidence-based treatment. So I do discourage, and I work with people on reducing their cannabis use and not use it for ADHD, even though colloquially people will recommend or say, well, my mother told me or this person told me. I would not recommend it as a clinician. Next. So when we move on to the non-medication approaches, again, I will mention that part of non-medication approaches is therapy. And part of therapy for ADHD is actually targeting the shame and sense of failure that comes with ADHD. It's a huge, huge part of ADHD. And often part of that is, again, as I mentioned, we only focus on issues. We focus on deficits. We focus on problems. People come to us because their spouse, their employer, their parents, somebody told them that they're bad, they're lazy. There's so many issues. That's all I hear all day is issues. Is they're an issue. They're a problem. They didn't live up to somebody's expectations. They disappointed somebody. They didn't do something, right? And again, it's usually a fact. Usually they have forgotten things. Usually they have done things that were, wrong or socially unacceptable or whatnot and judged, right? So a lot of the times it is important to address the self-esteem and shame and focus on strength-based approach. And I will mention to people, established people or famous people who have ADHD, who are open about it, just to kind of give our patients a different perspective of ADHD, that you can be capable, you can be an athlete, you can be a business person, you can be somebody not just a defect or a problem, right? So this is a list of people who openly and publicly spoke about their ADHD, including the gymnast Simone Biles, who won so many medals. It was a part of an issue about her getting her stimulants to when she was at the Tokyo Games. Michael Phelps, his mother was a principal and put him into swimming to manage his ADHD, right? So Brittany Griner is the basketball player who was arrested in Russia for having the vapes. And part of that was explaining that because of ADHD, she forgot to unpack it, which is totally believable for anybody who knows ADHD, right? So again, but caused a ton of issues. Richard Branson talks about his ADHD, and he's very creative, has come up with very successful businesses. Greta Gerwig is the director for the Barbie movie, and again, very creative. Trevor Noah, Johnny Depp, Javi Mandel, Karina Smirnoff from Dancing with the Stars, they talk about it. And I think it's very important for us not to just focus on deficits, but also that people can have lives, people can have jobs, people can be accomplished, and people could struggle. It's both. Next. So in terms of targeting non-medication approaches for ADHD, right, you have to look at what are you actually targeting after identifying, the issue that the client comes into you with. And that might be different for different people, right? I absolutely love DBT for ADHD. Absolutely cannot tell you how much. And there's now handbooks that people are coming up with. And the DBT, dialectical behavioral therapy, right? They focus on emotional regulation, assertiveness, interpersonal interactions, distress tolerance, right? And DBT in itself talks about opposites are true at the same time. And that's what I highlight of ADHD. ADHD is a condition of opposites. There's deficits and there's tons of strengths. There's, hyper focus and lots of interest-driven activity, and there's deficits and difficulties. You could be a physician by day and you could struggle with cleaning your room, right? You could be very smart and have high grades, and you could be completely overwhelmed and 5 years behind on your taxes, right? So looking at ADHD as a condition of opposites non-judgmentally from a DBT perspective is what I use, and I find the healthiest approach, because we acknowledge the issue and we move towards accommodations, education, solutions. So we're not invalidating the reality of the condition. We validate and we shift the focus. We don't stick in just the deficit model or just, well, this is bad, this is bad. This is what it is non-judgmentally. And how do we live with this? How do we look for accommodations from others? How do we learn skills how to live with it? How do we continuously learn how to coexist with this condition? It's just going to be there. You have to coexist. And the other opposite I say is that, look, it isn't fair. It's not fair that you were born with this. And this is what it is. So how are we going to live with this? How are we going to manage this, right? And so the emotional regulation skills of DBT are so, so important useful in ADHD. The other thing is because people with ADHD often turn into people pleasers to accommodate for their deficits, right? Assertiveness and boundaries are huge, very huge, very huge, because, they often struggle with boundaries, and they often struggle with boundaries because of the impulsivity. So learning about boundaries for yourself, how to protect your time, how to protect your energy, and boundaries of what you can handle versus boundaries in terms of other people and, sexual boundaries and things like that. Huge, 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 huge. There's obviously evidence, and CBT has been used for ADHD for a long time. Again, there was an article I included in the previous presentation is we can't use the usual CBT. We do have to adapt CBT for ADHD. When you expect people to do homework, it could be very re-triggering because you're putting them back to when they were in school and when they lost things and forgot things. I once had a client who was logging into the appointment while they're boarding the TTC, and they left their CBT handout on the previous ride on TTC, right? And it's like the handouts often stayed on the couch in my office before the patient left because of the forgetfulness. And then it triggers shame, it triggers sense of failure. They don't remember what we talked about. So we have to be very careful when we're doing structured and homework-based therapies with our clients, and we have to adjust and understand that ADHD will impair their ability to do therapy. And instead of judging them, because, that's what often we would say, you're not committed, you're not interested. So we would perpetuate that trauma by saying, you're not interested, you're not committed enough, you're not working hard enough, when they are doing their best and their ADHD is getting in the way of completing the same handouts that we expect them to do. So CBT is good, especially targeted skills, but just be aware about this potential perpetuation of shame if we're going to shame them for losing, forgetting, not completing homework. And I usually say, what got in the way? How can we make it better? How can we get you to do the homework that it's helpful? How can we do that? And it's problem solving. Mindfulness can be very helpful for ADHD. Again, mindfulness has to be adapted for some people. Mindful doesn't mean that you sit in one spot. Mindfulness could be mindfully walking, mindfully running, mindful movement. It does not have to be the mindful that people imagine it to be. It's looking how the person can do mindfulness that works for them and adapt it. ADHD coaching and skills are very important, particularly in the social aspect, organizational, financial aspect. Work and school accommodations are huge. They're key. Accommodations at school are key to scaffold people. Accommodations at work. And again, as I mentioned last time, I strongly advise people from disclosing the condition because, one, you don't have to according to the human rights. You just have to say you have a medical condition that, as per Human Rights Code, provides you with accommodations, which is true. And then list the accommodations. That's all you need to do. Physical activity and exercise, I listed some material on that, can be very helpful. It's not the main mode of treatment, but it could be an adjunct in helping manage ADHD as part of a big approach. And this is why often in COVID, when we lost access to the gyms, most of us went virtual sitting in our butts all day, and we lost that movement. A lot more people started struggling and again, unmasking the ADHD because they lost their compensatory strategy. Or when people go from, 7-day-week sports in high school to no sports in college or university, and all of a sudden they're struggling, it's because often that compensatory strategy was lost and people didn't realize what exercise did for them, right? Parenting programs and parent training. I use DBT when I run my groups for ADHD skills for moms. I use DBT skills for them and with their kids. Because again, parenting skills are huge. There's a lot of shame. There's a lot of sense of failure. There's a lot of so much stuff that comes up. Couples therapy and relational skills are very, very important because unfortunately, a lot of the times the partner who doesn't have ADHD finds it resentful, finds like they're the parent, they can't rely on the other partner. There's a lot of judgment, there's a lot of frustration. There's a lot of complex dynamic that happens with couples in relationships with ADHD. A lot of unrealistic expectation that, their partner's going to get fixed rather than a chronic condition. Cannot emphasize enough the value of occupational therapy. Occupational therapy 24/7, whether it's at work, whether it's at home, whether it's functioning in, again, different areas and domains of their life. Occupational therapy assessment and evidence-based approaches are really important because they are. Occupational therapy is evidence-based field. They provide evidence-based accommodations and anything that they need to do. And again, strength-based approach. How can we support you to achieve what's important to you? Not what's important to me, not what I think you should do. What is important to you? What are your strengths? How can you capitalize on your strengths? Let's focus on that. Next. Again, these are the psychotherapy targets I often target when I do therapy with my patients. Shame is huge, guilt, trauma, huge trauma. And often trauma because of ADHD. They might have been in an accident. They might have gotten into a situation where they impulsively met somebody and sexual assault happened. There might have been people pleasing that led them to not say no at a particular time, leading to an assault. Lots and lots of trauma. There's lots of self-esteem issues, self-confidence. They might end up in abusive relationships because, again, they struggle with people pleasing. They have shame. They struggle to say, I'm okay to walk away. There's issues with self-acceptance, emotional regulation, rejection sensitivity, even identity. Their identity is often, I'm a loser, I'm a failure, I'm not good enough, because it's often accumulated over the years of hearing that message, potentially from family, peers, partners, whoever, work. So there's this deep, deep, deep issue of internalized defectiveness, failure, and who they are. They often have cognitive errors of all or nothing thinking. I'm either good, I'm bad, I'm good or a failure. There's a lot of personalizing, it's all my fault. It's, and they're so quick to often take on the blame. And so there's often quite a few cognitive errors that run together. Next. So again, this is just a little bit of some of the examples on DBT. And there is a study from a group in Europe that they do groups. This is the dialectics, and this is some of the suggestions that I would make. Next. Imposter syndrome, it's literally mentioned in GATRA guidelines, but it's a huge core feature of ADHD because there's often inconsistent performance, especially under different environments, under different stressful situations, under different accommodations. You know, people will often struggle with one, taking credit for success, but also feel consistently good enough. They constantly feel like, I just pulled it off. I pulled it off. And because sometimes, unfortunately, they do pull things off the night before because of procrastination, they will say, well, yeah, I just did it last minute. I can't predict my function the next day. Or because there's been perceived failures and they feel like I fooled people, I just pulled it off. I see this a lot in physicians. I see this a lot in professionals where like, if they only knew who I am, they mask it. And the imposter syndrome is huge, huge. And the higher they go up in responsibility or role, the bigger it gets. And often that's when they start drinking. That's when they start struggling because they're like, oh my God, well, if they only find out what a loser I am, if they only find out that I did the presentation last minute, right? It's just huge. So it's a big issue in imposter syndrome and ADHD, huge. Next. Again, there is a group therapy in GTA that is run by psychiatrists. It's OHIP covered. The wait list is huge, but they do accept parents. And then there is the tele-CBT that I know they used to do some CBT for ADHD. I don't know if the resource there. I have no affiliation with either one, but that's OHIP covered resources. And it is virtual, but it is still available. So this is just information on physical activity, just a kind of review of literature on physical activity and what it might help. It's not the main modality of treatment, it's an adjunct. So it's good for that.